Hello, and thank you for joining. Our webinar, Shifting Focus from Pain to Function, will begin in just about 5 minutes. We'll give everyone just a couple more minutes to join and get settled before starting the presentation. Hello, everyone. Welcome to the Concentra webinar, What Employers Need to Know about Shifting Focus from Pain to Function. Today's webinar will be presented by Dr. Maja Jurisic. Dr. Jurisic has practiced with Concentra for nearly 30 years of her 40 years as a physician. She has board certified in emergency medicine and occupational medicine and is a leading advocate of a pain scale alternative that is helping to lessen opioid use. Dr. Jurisic is also a consultant to the Department of Labor, serving 8 states under a federal initiative to improve return to work and stay at work outcomes for injured employees. At the conclusion of the presentation, we will have a 10 to 15-minute Q&A session with Dr. Jurisic. You can submit your questions throughout the presentation to be answered during the Q&A session with Dr. Jurisic. We will answer as many questions as possible within the time allowed. A recording of the webinar will be emailed to you after the presentation so you can view it again at your convenience. Dr. Jurisic, we're ready to begin.
Thank you, Anna, and thank you all for joining us this afternoon to learn more about a topic that I think is really important to all of us, not just in our work lives, but also in our personal lives. And really an alternate title to this presentation could have been Ending the Reign of Pain, which I think actually started in this country around the turn of the century. Towards the late 1990s, actually, the American Pain Society, which was, by the way, largely funded by Purdue Pharma, offered up the idea that we were undertreating pain in the United States, and they advocated including pain as the fifth vital sign that should be measured at every patient visit. And the Joint Commission on Accreditation of Healthcare Organizations jumped on this pain bandwagon, and they launched a campaign in 2001 to treat pain more vigorously. And as they traveled the country, inspected healthcare facilities, and decided whether or not to accredit them, one of the things they checked was whether that institution was using the visual analog pain scale. That's the chart with the happy and sad faces corresponding to how much pain someone is feeling. And since hospital systems couldn't take care of Medicare patients unless they were accredited, everyone made the use of the pain scale mandatory. And pretty soon it was so baked into the system that when I recently took my 93-year-old mother to see her orthopod just in an outpatient clinic visit, we couldn't even register her until she told them what her pain was on that visual analog scale. And, you know, hearing all this, hearing that they had a right to adequate pain control, some patients interpreted this as a right to be pain-free, and physicians felt pressure to rid their patients of pain, and in fact, some of them were reprimanded if it was thought they were under-treating pain. So I'm going to spend the rest of our time together sharing why Concentra decided to throw out the pain scale, and not the least of those being that after the pain scale became ubiquitous, there was an alarming rise in the prescription of pain medications, as well as overdoses and deaths of patients due to prescription opioids. And I don't think that was a coincidence. I do think they were related. So as you can tell, I don't think that visual analog pain scale has been serving us well. In the 40 years since I graduated from medical school, we've actually learned some very interesting things from research in the neurosciences. In medical school, we learned that, you know, our brains mature until adulthood, and then it's pretty much a matter of losing neurons until you die. And that's kind of a bleak picture. But we now know that's not true. We've learned that our brains have neuroplasticity, which means that they can reorganize themselves and continue to form new connections throughout our entire lives. And by choosing which neural pathways to activate, we can actually change our brain anatomy. So the more we activate particular pathways, the denser they grow and the faster they become at sending messages. Neuroscientists have taught us that where attention goes, neural firing flows, and neural connection grows. And when you think about that, it's really a pretty fantastic superpower if we choose to use it. Unfortunately, pain is the dark side of neuroplasticity because our brains are not passive computers that just receive and register pain signals, but because they're actively involved in either shrinking or growing pain. Studies have shown that focusing on pain actually lights up pain regions in the brain. A patient can literally grow pain by thinking about it and how terrible it is. So how and how often patients think about their pain can actually make their perception of it better or worse. And at Concentra, we've learned both from looking at the literature and from our own patient data that focusing on function is more effective in helping people to renormalize their lives after they've been disrupted by a work injury than harping on pain. And this is particularly important in cases where a patient's subjective complaints exceed the objective findings, because we know that pain is not invariably a signal of ongoing tissue injury. Next slide. The most widely accepted definition of pain comes from the International Association for the Study of Pain, and it states, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So two important takeaways from this are that pain is an experience with an emotional component, and it may or may not be associated with tissue damage. How people think and feel about their situation can determine whether their pain gets better or worse. If they're afraid or angry or stressed, they feel more pain. If they're calm, if they feel heard, if they feel that their employer and or their doctor really care about them, they feel less pain. And pain pathways can become persistent if they keep being activated, like when we repeatedly ask patients to rate their pain. So that's why some people continue to feel pain even though their tissues are healing. And it's also possible for the perception of pain to come and go depending on whether the danger signal in the brain is activated. Next slide. The title of this next slide is "The Reign of Pain Lies Mainly in the Brain." That's a statement of fact. The way we're wired, all of our body parts have sensors that trigger constant messages to our brain about our current state. And these messages are electrical impulses. We have millions of sensors scattered throughout our joints, our muscles, our ligaments. But, and this is a big but, these messages, these electrical signals are not pain. They are danger messages. Pain is something totally different. Pain is made by the brain 100% of the time. Our brains make pain when they conclude from these messages that we are in danger and we need to do something about it. And pain is one way of making us pay attention. And both physical and emotional injuries activate the same danger signal, which triggers pain. To our brain, it's exactly the same, whether it's an emotional or physical danger. And I think much of the confusion comes in when people don't differentiate between the two, because sometimes frankly, it's easier to deal with a physical injury than it is to deal with some emotional issue like, a relationship that needs fixing. So however nasty it is, pain is proof that our nervous system really looks out for us. Your brain, my brain, everyone's brain is wired to do its best to keep us safe and to ensure our survival. And nearly anything can provide credible evidence of danger. The diagnosis someone is given, the words a supervisor or an adjuster uses if the employee perceives them as negative or maybe threatening, seeing findings on x-ray or scans like degenerative changes, even if the doctors tell the patient that those kinds of findings are not clinically significant, degenerative changes sounds pretty scary. And in their valiant attempts to keep us from harm, our brains sometimes get it wrong. One well-known case where this happened was a construction worker who stepped on a nail. It went in the bottom of his shoe, came up the top, sticking out, and he was in a lot of pain. He was thinking about, gosh, this foot is so complicated. What if I've really screwed it up? I don't have other skills. I really need to be able to stand and walk. And so all these thoughts about, will I be able to return to this job? I make good money. How will I pay my mortgage if I can't work, construction, etc. All of this was going on in his mind, and by the time he got to the hospital, he was in agony. So before they did anything else, they did an x-ray of his foot, and the doctor came in smiling and said, "Hey, you were really lucky. This nail went in the space between your big toe and the next toe, and so you didn't damage any tissues that are important." And all of a sudden, this agonizing pain, just like that, went away as the brain realized, oh, I'm okay. There's no big danger here. So we have to sometimes be careful. And, our pain system can become overly protective. You've probably heard the phrase, practice makes perfect. So when someone has pain for a while, the nerve cells in the spinal cord and the brain actually become more responsive. And that person's pain system becomes more efficient at producing pain. It learns pain. So just as when you learn a new skill, like playing the piano, the nerve cells change their properties to be more responsive. Our bodies have remarkable healing powers. We really are designed to heal after musculoskeletal injuries. So as time passes, if the post-injury pain remains and a patient's sensitivity doesn't go away, it's unlikely that the injury is getting worse and mysteriously spreading. What's happening when patients complain of more pain over time, despite appropriate treatment, is that their pain systems are becoming overprotective. So when an injured worker complains that the pain is moving from one side of his body to the other, or from one location to another, or new spots are getting sore, or the patient is experiencing frightening muscle spasms, those are usually signs that his body is trying to protect itself and not a sign of further tissue damage. And all of these things show that the patient system is on alert. This pain can actually be turned up and down by thoughts, feelings going on in that person's life, things that have nothing to do with the painful body part. So if a patient comes in and says, I don't know why, but I'm hurting more this week, instead of rushing to find a new pain generator and ordering an MRI or referring to a specialist, a savvy clinician will take a step back and try to figure out what else might be going on in this person's life that might seem threatening or dangerous to his brain. So one example I can give you is a patient I saw once when the employer actually called me and said, I have this guy who's been just a great employee. He's always been a hard worker. And he hurt his back a while ago, and he's just not getting better. And, he's scared about it, and I'm a little concerned too. We just don't know if the doctor who's seeing him is doing everything he should to investigate. And so I said, well, I'd be happy to see him if you're that concerned. And I called the doctor, who actually is one of the most brilliant physicians I've ever met. So I kind of doubted he was overlooking anything, but I said, would you mind if I see this patient next time he comes in? And he said no. So I showed up for the patient's next recheck. And the first thing I noticed when I walked in the room is that he just seemed really scared. And he told me, Doc, I've played soccer on a team on weekends for like over a decade, and lots of times I get hurt, but I always heal really fast. I've always been a good healer, but this time it's been 6 weeks since I hurt my back, and I just don't feel any better, and I'm really scared. I'm wondering, if there's something terrible going on. What have I done to my back that it's just not getting better? And so I did a very careful exam, and there was really no evidence of nerve root impingement or anything more serious going on underlying his back injury. And as we were chatting, it kind of came out that he hurt his back about the same time as his wife left him. She left him for another man, left him with 2 kids to take care of on his own, and he wasn't sleeping well. He wasn't eating. He actually just didn't have an appetite and had lost about 20 pounds in 6 weeks, which is a lot. And he wasn't a heavy person to start with. So we kind of talked about the fact that healing, requires that you give your body the building blocks it needs to heal. So nutrition is important, good protein, minerals, vitamins, etc. How most of our healing takes place during sleep. So restorative sleep is really important. And we talked a bit about sleep hygiene. And, he said, so you really think that it's these things that will help me get better and there's nothing more serious going on? And I said, yeah, I think so. And so he said, well, I guess I feel better about that there's something I can do to get better. And so I called the doctor treating him the next week to see how he was doing, and he was a whole lot better. And the week after that, he was discharged. And it's just because that kind of danger signal turned way down and he was able to start feeling better. Next slide. One thing we know absolutely for certain is that an overprotective pain system is not a sign that someone has a weak personality or a weak mind or is exaggerating pain symptoms. It does mean that this person's neural pathways were altered so that his or her pain system became overprotective. The CDC has been doing studies actually since 1998 on what they call adverse childhood experiences, or ACE studies. And they've shown a stunning link between childhood trauma and things that happen to people in adulthood, both chronic diseases and social and emotional problems. They've done more than 60 of these studies, and they showed that childhood trauma is actually very common and not just in deprived areas. It's experienced by many employed, white, middle-class, college-educated people. There's a direct link between childhood trauma and adult onset of chronic disease, like heart disease, diabetes, as well as depression, suicide, addiction, alcoholism, and the more trauma and adverse experiences, the higher the risk of these problems. And the study's researchers came up with a score to kind of stratify someone's risk, and they gather this score by asking about 10 types of childhood trauma, things like physical, verbal, or sexual abuse, physical and emotional neglect, whether someone had a parent who was an addict or in prison. And when an ACE score is 4 or greater, that's when things start getting serious. The risks really increase. So these higher ACE scores correlate also with impaired work performance, with more absenteeism, problems performing the job, and delayed recovery when someone is injured. So I don't think it's a coincidence that the number of people who have an ACE score of 4 or more is about the same as the number of patients who have delayed recovery after a work injury. The CDC estimates that 10 to 12.5% of the adult population probably have ACE scores that are higher than 4. So the next slide. So when I started at Concentra, I was really kind of baffled by cases where I was doing everything I was supposed to do as a physician. I was evaluating the patient, coming up with an accurate diagnosis and appropriate treatment plan, but the patient was refusing to get better, and at least that's what it felt like to me. And I was following the standard medical approach, so it was tempting to blame the patient. And it's not unusual to hear frustrated physicians talking about bad patients or difficult patients when they're discussing cases where people are not getting better as anticipated. But what was really going on is that we were using an ineffective approach, and instead of changing strategies, we continued looking for the pain generator. So when we saw that this standard medical approach lacked efficacy and it was not helping our patients in the more challenging cases, and that repeatedly asking about pain just made those pathways grow and patients thought about them, and also quite logically made patients believe that their perception of pain was a reliable way to measure healing, because otherwise, why would the doctor keep asking about it? So we knew that there was a human being attached to every injured body part, and that it's this human being's unique reactions to his or her work injury, his thoughts, beliefs, emotions, expectations, his view of what's possible and what the future holds, that these things all counted in recovery from a work injury. The way an injured worker views and interprets his situation, what he thinks about, really drives that person's behavior, which in turn has a powerful impact on the outcome. So we decided that instead of prompting the worker to think about pain, we would focus our conversation on function, on what and how much the patient was doing, rather than how much pain he was feeling. And we came up with FRESH, next slide, which is an alternative to the pain scale. It stands for Functional Restoration Status of Healing. So we still do use the pain scale at the initial injury visit. Acute pain actually correlates pretty well with the severity of the injury. But at recheck visits, we use the FRESH scale. So if somebody is getting physical therapy, our PT colleagues gather and document the objective measures of function, and they're based on the patient's actual job. So if someone has to lift 100 pounds at work, that's their functional goal. If it's 50 pounds, that's their functional goal. So we don't have some universal goal that everyone has to meet to be considered at functional restoration. And then at every recheck, medical clinicians review this and they choose a stage of functional restoration or healing. And it goes all the way from stage 1, where somebody has significant difficulties with physical requirements, to goal. This is really a more objective and helpful way to measure recovery and to change the conversation. It actually helps clinicians change the conversation, because we've all become used to asking about the pain scale too. That's, like I said, become an ingrained habit because that's what everyone expects you to do. This FRESH approach gives patients a defined functional goal that they're working towards. And as treatment progresses, we look at the progression of objective measures to determine how someone is recovering rather than relying on every little nuance of pain. Most patients actually don't start at stage 1. Most actually start at stage 2, 3, 4, or 5. And then we encourage patients to keep pushing the envelope and to do a little bit more at every recheck. Ideally, we'd be able to move a patient to a different stage at every recheck, but that doesn't always happen. But even if that doesn't, that's a good time to encourage patients to remain consistent and persistent in their own efforts to further their recovery. Centering the conversation around functional restoration and the progression of healing process as the goal of treatment, and helping patients understand that they are and should be active participants in their own recovery, is what we believe to be a best practice in the work comp arena. So some of the differences between the pain scale and FRESH. The pain scale is a subjective system to measure patients' self-reported pain. It's not a reliable indicator of the healing status. Pain perception is not necessarily associated with tissue damage. Fear, anxiety, and stress all fuel the perception of pain. FRESH is a new way to measure progress. It emphasizes functional restoration. It encourages patients to actively engage in recovery. It helps reduce their need for pain medication and hopefully increases productivity and gets the patient a better outcome, which in our world usually is shorter case duration. Next slide. So this is a different way of looking at this, what we would consider a quality medical outcome, and why we shift from pain to function. So it changes the focus from subjective to objective, and the patient-physician conversation moves from disability to ability. We highlight the progress made. We celebrate that, even if it's, they can bend further than they could before, or they're now able to walk around the block before they could only walk half a block. And we try to help them to think more about all the things they can do rather than the things they can't do. Next slide. The benefits of this approach is that we're hoping to reduce opioid utilization, increase productivity, and improve outcomes, and especially by avoiding creeping catastrophes, those cases that start out with a minor injury, but over time, step by step, almost imperceptibly, they end up becoming a work comp disaster with needless disability and needlessly ruined lives, largely because the medical system clung to a stale approach. Next slide. So we measure everything at Concentra, and we never were a huge user of opioids, but before we started this FRESH approach, we used opioids in 8.2% of our cases. And you can see that every quarter since we started, that has gone down to the point where we are now at 3.1% of cases having opioids prescribed. So that's a 62% reduction, which is pretty good. Next slide. So just kind of final thoughts. This paradigm shift from focus on pain to focus on function really offers hope that even the most vulnerable injured employees can avoid delayed recovery, and they can get back to normal after the disruption of a work injury. Our average case length is 17 days, and honestly, most of our patients recover smoothly and uneventfully, and they would probably do well with or without us, because our bodies are designed to heal. But in about 10% of patients, actually about 6% in our setting, but people talk about in the work comp arena 10 to 12% of patients, the segment of the population gets stuck and they just don't get better as anticipated. Their recovery is delayed. And when I first started practicing occupational medicine, I assumed that most of them were exaggerating their pain complaints and they were playing games. But I was wrong. Over time, with experience and actually doing a lot of reading, I realized that most of them were people who just didn't have a lot of resilience left, And what seemed to me to be a relatively minor injury pushed them past their coping skills, and so they failed to improve, even though my diagnosis and treatment plan were on target. And unfortunately, Western medical training just doesn't give physicians very good tools to help these patients. Typically, what we're trained to do is when patients keep complaining, we're trying to keep looking for a pain generator, something that we can fix, because once we identify it and fix it, presto, the case is over. But that isn't true with this subset of patients. Even if they have, let's say, a rotator cuff tear, and that's repaired, if they also had pain complaints that were fed with their emotional experiences, something else going on in their lives, and we didn't even touch about that, they will continue to feel pain even after the most fabulous surgical repair of that rotator cuff. And when nothing they do seems to help, when physicians don't feel like the healers they want to be, they throw their hands up in frustration. And in the work comp arena, when the employer and the payers see that a particular case is taking way longer than treatment guidelines say is appropriate for the diagnosis, they often send that patient for an IME. And when the IME doctor says, hey, this person is at MMI, there's nothing more to do, it's finally over. And it is over for the doctors, for the employer, for the payer, but it's not over for that patient because that person is still in pain. And if the patient got the standard therapeutic approach, where he was asked about pain at every visit, that actually might have pushed him down that maladaptive pain path to ongoing pain. So with our fresh approach, our focus on function instead of pain, we're hoping for better outcomes for even these most vulnerable patients. So when we ask about activity and exercise, about nutrition and sleep, the triad of wellness, rather than asking about pain first and foremost, we're taking a fresh approach. When we're taking care of patients whose subjective complaints exceed objective findings, whose pain we believe is being fed by emotions rather than structural or tissue damage, and we focus our questions on what and how much they're doing rather than how much pain they're feeling, we're taking a fresh approach. When we explain the neuroscience of pain to these patients and reassure them that there's not something truly horrible going on with their bodies that no one has as yet uncovered, we're taking a fresh approach. When one of the barriers to recovery is a patient's negative and dysfunctional way of thinking about and dealing with his situation, and we help that patient to reframe to think differently, we're taking a fresh approach. Helping these most vulnerable patients cope better, getting them back to normal life, not only benefits the patients and saves their employers money, it also activates the reward centers and physicians' brains. It really does get us excited and delighted. So it creates a win-win-win situation. So I invite all stakeholders in the work comp arena, all of you on the call, to help us end the reign of pain. Stop using non-acute pain as a measure of injury severity or healing. Talk to your injured employees about function, help them get back to normal, and avoid that ubiquitous conversation about pain. So if anyone has any questions, I'd be happy to try to answer them.
Hi, Dr. Jurisic. We have a question from Tina. Can pain cause blood pressure to increase?
In the acute setting, it can, not chronically. So when someone, let's say they fall down and they land on their tailbone and it really hurts, yes, that can increase blood pressure, but not if it's a week later or even days later. That you can't blame it on that.
We have another question from Kimberly. When we have an employee who chooses another provider than Concentra, is there a way that we can help the employee and the other provider move more to this model? As a nurse, it seems like getting them to hope is good.
Yeah, I would agree. Getting people to hope is fabulous. But I really don't think there's a whole lot we can do if they decide to go elsewhere. I do think that there are more individual clinicians out in the landscape, recognizing that talking about pain is not helpful and possibly harmful. And some of them are choosing not to do it. But I think it's going to take a while until we get to the tipping point where entire systems stop doing this, just because it's become so baked in. But yeah, when I talk to physicians sometimes, physician groups outside of Concentra, and they, invariably someone will come up afterwards and say, "Oh, I stopped asking about pain years ago because I realized it wasn't really helping anybody." But I think unless the person happens to choose a physician who is of this mindset, there's not a whole lot you can do other than try to offer them the idea that hey, we've heard that function is a better way to help people get better, focusing on that rather than pain, and see if they bite.
We have a question from Francis. Can you give an example of what types of questions to ask an employee under a fresh approach instead of asking about his or her pain level?
You can ask, how are things going? You can ask, are you sleeping okay? And you can have a little talk about that if they're not. You can ask, how active have you been? Are you able to do your home exercises? Are you able to, get through your day, do your activities of daily living, that kind of stuff. You can ask about nutrition. You can ask if they're, trying to make sure they're including quality proteins, eating fresh fruits and vegetables to help their body to heal so it gets all the nutrients it needs to actually do that. Those types of things are helpful. And just knowing that you care enough is helpful too, because every time the patient feels heard and understood, that perception of danger goes down, and that's what helps promote healing. We could talk a long time about our autonomic nervous system and our sympathetic and our parasympathetic nervous system. So when people are stressed and they feel danger, the sympathetic nervous system is activated, stress hormones are released, a lot of negative things happen in our bodies. And I'm not saying the sympathetic nervous system is all bad. It's there to preserve us and protect us in life-threatening circumstances. But in the world we live in, once it's activated, it tends to stay active because the situation isn't changing that quickly. It's not like in prehistoric times, a caveman was being chased by some large animal and sympathetic nervous system activated. He ran away, got away from the animal, that can shut down. But these days that, somebody's injured, and until that whole injury process is over, if that system is activated, unless you consciously try to deactivate it, it will stay online. The parasympathetic nervous system is kind of the growth and development, the rest and heal part of our autonomic nervous system. So anything you can do to activate that, which is when people feel social connection, they feel safe, that's when the parasympathetic nervous system comes online. And unfortunately, the work comp system can seem scary and sometimes adversarial to injured employees. And that actually becomes a barrier to healing. So anything you can do to promote a feeling of safety, a sense of caring, a sense of connection with your injured workers, that is all to the good, and that actually promotes healing.
All right, we have another question from Catherine. I'm an employer who has an employee who has had every test done. Doctors can find no further reason for existing pain, and her functionality is not impeded in any way, but she is still complaining of pain and fighting the closure of her case as she feels her injury is not resolved. How can I advise her as an employer and not as a medical professional?
Yeah, well, those kind of situations where everything is investigated and all the tests are negative, it seems that unless she is one of that tiny, tiny fraction of people who truly are malingering, if she is still feeling pain, she has what is a neural pathway problem. It's now called a psychophysiologic disorder. And there are some physicians who are very good at explaining that to people and closing it down. There are actually videos on YouTube that are very good at explaining pain. And there have been studies done that show that when people understand that this pain they're feeling might not be a valid signal of tissue injury, but it's just a danger signal that is persisting because of their overly protective or very protective nervous system, that just knowing that helps that pain to resolve. There's actually a very good, it's less than 5 minutes, it's a clip that's actually put out by the Department of Defense. If you just go to YouTube and you put in explain pain to patients, a lot of stuff will come up, and you can find that Department of Defense one. There's also one that's very similar to that, that's put out by the Australian government. So there are those kinds of things that you could, maybe help them find and view, because they can be helpful if they suddenly understand, gosh, this isn't something horrible that people are ignoring. I've had all the tests. So if I understand that it's because my brain is trying to protect me, that calms those neural pathways down enough that the pain subsides and becomes more manageable. Might not go away completely just by watching a video, but it should get better. And like I said, there are some physicians who are very aware of this and are finding ways to have this kind of conversation with people that calms down those overactive pain pathways. Unfortunately, there are way more physicians who don't do this, which is, I think, part of the problem in our medical system. And I'm really hoping that at some point we'll get to kind of that tipping point where this is just standard practice, this is standard of care, that we share this kind of knowledge and information with patients so that we don't inflate their sense of some physical problem when really it's just their brain maybe getting it wrong and deciding there's danger where there isn't.
Thanks, Dr. Jurisic. How should an employer talk with their local Concentra clinic about the fresh approach?
I guess that depends on the situation. It's hard to say. Just, let them know you're aware of it. And if you have concerns that there isn't a progression from visit to visit, that would be a good thing to talk about. You can talk to the clinician about, or the physical therapist actually, about, how is this person coming along as far as functional restoration? What is the goal that we set, and how far along are they on the path to that goal? It's new for us too, so the clinicians are still kind of learning to navigate a different world than they've been used to in all of their training. But yeah, I think it's a great thing to talk about, and I think if we all talk about it more, and patients hear about it, and they hear the message that pain is a construct of your brain that's trying to keep you safe and make you pay attention to some part of your body that it thinks might be in danger, that's a good thing to do.
Thanks, Dr. Jurisic. We have a question from Natalie. With this model, are more patients referred to therapy sooner and more often?
No, they're not. Our referrals to therapy haven't really changed based on this. It's just that the documentation in therapy is a little bit different, because now they have this little template where it shows the fresh goal and where they are on their way to this goal. But the referral rate hasn't changed at all. And obviously, if they aren't getting therapy at Concentra, we're dealing with therapists who are still talking about pain because that's what they were taught to do. And so we just, as physicians, we just have to guess where the person is based on our physical exam, rather than having the therapist's notes as, they were lifting 10 pounds when they started, they're now lifting 40 pounds, they're almost there. If they're not getting therapy at Concentra, not only is it a delay to get that kind of information, but depending on where the therapy is being done, sometimes we don't have that kind of information at all. They just document what they've done with the patient.
Thanks, Dr. Jurisic. We have a question from Will. How do we apply this approach with people with degenerative nerve conditions?
That's a hard one to answer because that covers a lot of different territories. We actually don't see a lot of people with degenerative nerve conditions. There are a lot of degenerative changes in the bony structures of our body, but you know, a lot of the conditions that in the past patients have maybe thought of as a degenerative nerve condition, as it turns out, really are psychophysiologic disorders. In the world of medicine, if we keep seeing a certain problem and we really can't seem to put our arms around it or define it very precisely, sometimes it gets a name. We medicalize it. And one example I can tell you of this is like fibromyalgia. It's a constellation of inconsistent findings that I think physicians felt uncomfortable dealing with, and so they called it fibromyalgia, and they created a medical condition. And the physician who first did that actually has since recanted and said he's sorry he ever kind of postulated that diagnosis and that it was accepted in the world of medicine, because he feels that from what he's seen since he first came up with that diagnosis, we're kind of medicalizing misery, because a lot of the people who are given that diagnosis really are shifting their attention to physical symptoms that arise from other issues in their lives. And until they deal with those issues, their physical symptoms won't go away.
Thanks, Dr. Jurisic. We have a question.
Oh, go ahead.
I'm sorry.
I was just going to say that's not all degenerative nerve conditions. There are some real degenerative nerve conditions, but those are very rare, and those people usually aren't in the working population if they're advanced anyway.
Okay. We have a question from Keith. How does an employer communicate suspected fraud?
Communicate to whom? To the physician? If it's to the physician,
if they have concerns about the employee.
Yeah. Well, the easiest way is just to call and talk to the physician taking care of the patient. I always appreciated those kinds of calls. And, like I said, when I first started working in the work comp arena, I was very suspicious. I'd been an emergency physician for 11 years. I was lied to a lot. I was pretty cynical. And so when people came and they had a minor injury, I mean, not a big deal medically at all, and they had all of this severe pain, I would just kind of internally roll my eyes like, yeah, sure. And especially if they then were not getting better, even though, let's say they had an ecchymotic swollen ankle and it looked fine. It was, 2 weeks had passed, we had treated it. It looked like a completely normal ankle, and they were telling me their pain was even worse. Again, I would roll my eyes internally and think, yeah, sure. So the trick in the world of medicine, and that's why it's a science and an art, is you have to try to clarify in your own mind as a physician, is this person really a malingerer, or is this just somebody who has a dysfunctional way of dealing with his situation and is feeling pain that is not correlated to tissue injury? So if an employer has a suspicion that someone is a malingerer, I appreciate knowing that, and I appreciate knowing why they're suspicious, because there are people who are serial con artists, and they make up things with an end in mind, but they're very, very few and far between. And if somebody truly is malingering, what we need to do is discharge them. It's a waste of time, effort, and everyone's money to keep them in the medical system. And what I found is that those kind of people are actually very easy to discharge. The first time I had to do that, it was actually a guy who had just gotten out of the high security prison system in Wisconsin. It was his first job after prison, and he was faking it. And when I realized that, it was a little scary to think about telling him that I was going to discharge him. So my medical assistant at the time was like very tall and strong, and I'm pretty strong. So I asked her to come in the room with me because I was afraid that, like, what if he tries something? And I figured, 2-on-1, we could probably handle him. But it was easy because if somebody truly is just malingering and they realize the con is up, they shrug their shoulders and move on. And you don't have to call it out. You can just say, gosh, based on the mechanism of injury, based on the treatment we've provided, based on the time that's elapsed, I'm really confident that you can get back to your normal activities and regular duty with no problem, so I'm going to discharge you. And if they say like, well, you're wrong, I'm hurting, you can just say, well, we can agree to disagree, but this is my medical opinion and that's what I'm putting down. And like I said, a malingerer usually will not argue much. They might, give it one little try, but then they move on because they can. But somebody who really still is feeling pain will look at you with these hurt eyes, like, how come you don't understand my suffering? So, any kind of additional information we get that can help us distinguish between those two situations is very helpful. People's behavior and is very much usually consistent with previous behavior. So if somebody has, kind of been fraudulent or involved in fraudulent activities in the past, that increases the chance that they are again doing this. So it's not like we'll just say, oh, thanks for telling me, I'll discharge him right away. No, but it's certainly something we'll consider carefully in looking at the whole situation. It's one of the things that is going to be a piece of information in all of the information we have in thinking about this case and arriving at a determination. So, every little bit of information helps.
Thanks, Dr. Jurisic. Is the FRESH approach related to what's called cognitive physical therapy?
Could you repeat that, Anna?
Yes, sorry. We have a question from Francis. Is the FRESH approach related to what's called cognitive physical therapy?
Well, I'm sure it's related. There's no like formal line from one to the other, but a lot of the ideas and the principles behind it are the same, yeah. And our physical therapists actually have a lot more patient conversation time than the physicians do typically. So many of them are very enthusiastic about this change in focus. And we actually send out clinical messages to our clinicians every day. They're short, they come in their email. We know they're reading them because we can check that, or at least opening the email, we can check that. Every day has a different focus. I always do the Thursday messages, and I usually like to do messages about dealing with these kinds of challenging cases where people seem stuck. And I get a lot of responses, actually more responses from physical therapists than from our physicians, because they're very engaged with this, and they're very eager to use it with their patients and very eager to share the successes they've had where, by changing the focus, they had a different kind of conversation, and this patient suddenly had like a breakthrough and things just went down a smooth path afterwards.
Great, thank you. We have another question from Kimberly. She starts by saying, I meant to thank you for this. As a reformed ER nurse, that was part of my issue as well, very, very cynical and suspicious at times. After we maintain the fifth vital sign, how can we help get the idea of fresh type assessments and function across other providers? We are trying to combat opioid addiction. As a healthcare community, it needs to be pushed just as much.
Yeah, well, talk about it, spread the word, encourage people. I mean, there's lots of books out there that have similar ideas. I mentioned that there are some physicians who are very good at this. There's actually a physician, I think he's an internist by training in Detroit, named Howard Schubiner, who wrote a book called Hidden from View about these kinds of conditions, and he outlines actual steps. When do you consider this? he even has like sample conversations with patients in there. How do you talk about this? How do you help people work through this? And he's had great results. He hasn't specifically worked with the comp population, but he's worked with patients who have had chronic pain for decades, and within a very short time, they're off meds and functioning at a much higher level, re-engaged in living a full life when they had kind of stopped doing that for a long time.
Great. We have a question from Terry. How long would it take a young patient to recover from a traumatic brain injury?
It depends on the brain injury. So it's hard to say. And it, partly depends on the treatment and the patient's circumstances. Nobody recovers in a vacuum. So that's why a lot of my messages to clinicians on Thursdays are understand your patient in the context of his environment. You have to know that, you have to be familiar with that, or you're not going to know how to best help your patient get to the best outcome. So, does the patient have a supportive environment or not? What other resources are available to this person as they're dealing with this? It all makes a big difference. It was shocking to me when I first learned that some of the patients that we were seeing were homeless. It's going to take a homeless person. It's more challenging to recover. This poor guy was, I asked him, are you doing your home exercise program? And he said, no. I said, well, oh, why not? And he said, well, I can't do it in the homeless shelter because other people look at me funny. And so we worked out that he could actually come to our physical therapy department to do his home exercises, even when he wasn't having therapy, so he could do that. But, you have to know the circumstances and the context of someone's life to understand how you can help them recover.
Thanks, Dr. Jurisic. We have a question from Janine. I have a lot of employees that are caregivers that have residual pain but can't distinguish between being injured and having pain. How do you help work through that with the injured worker?
Yeah, that's a tough one. And it's also tough in a work setting because, there's always that little barrier is maybe too strong a word, but there's that little line that sometimes you don't want to cross between employer and employee. You're not their friend, you're their employer. You can certainly care about them and have compassion, but there's certain things they might not feel comfortable sharing with you that they would with someone else. So just helping them to understand that pain might or might not be correlated with the tissue injury, that pain can also be our brain's way of pointing out other problems going on in our life and in our circumstances. It doesn't always mean that there's a physical issue, and that when we deal with some of these other issues, the pain gets better. My sister happens to be a physical medicine rehab doctor, and she said what she's noticed is that it kind of goes both ways. Some people, when they start therapy and they're kind of working on some of their body issues, their emotional other issues that were contributing to the pain start getting better. And some patients, when they start dealing with the other sources of pain in their lives, maybe it's a husband or a child or something, when they start dealing with that, then their physical pain gets better and they didn't really do anything for the physical pain. Dr. Schubiner has a story of, he saw a woman who was having pain in her left buttocks for probably 4 years. And she'd been to every doctor, she'd had every scan and test done, and nothing helped. It was just miserable. And so as he was talking to her, he just kind of asked, well, what else happened in your life or was going on in your life about the time you started having this pain? And it turned out that was when her husband retired. And then they kind of figured out that was contributing to her pain. So her husband was literally a pain in her butt. And once she started dealing with that, they kind of, they chuckled a little bit about it. But once she started dealing with some of the issues that her husband's retirement had brought, then that pain went away, and he didn't really have to do much of anything else but help her realize that those two things were connected. So if you can just, if you ask enough questions, you can sometimes help people to recognize that two things that they hadn't connected actually are connected, and that realization can free them of the pain.
That's a really great story, actually, Dr. Jurisic. We have a couple more questions.
Well, actually, let me share another story, because this was really dramatic. This is when I worked in the emergency department, and this woman was brought in by ambulance, and she had suddenly, in like the space of 2 seconds, become paralyzed from her waist down. Now, medically, that's impossible. You can't just be sitting there and suddenly be paralyzed on both sides, because that's not how we're wired. And I took this big, pin that we use to test sensation, and I was poking her pretty hard, and she felt nothing. And so I figured that this was not a physical structural trauma issue, and we actually admitted her to psych. And she came back a couple weeks later to tell me what had been the problem. She was married to a man who just was a spendthrift, and he would just spend everything. And she was sitting at home waiting for him to come with his paycheck, because electricity was due, rent was due, phone bill was due. And so she was just waiting for this. And on the way home, he stopped at a bar and treated everyone to drinks and spent all the money. And then when he came home and told her, she said she had been dealing with this for so long, she just couldn't deal with it anymore, and it paralyzed her. And I was just, I'd read about this, but to actually see it was really impressive at how powerful our minds are.
Wow. That is quite a story. We have just a couple more questions, and then we'll need to close it out because we're coming up on the end of our time. We have one from Dulce. If the employer would like to call the physician to make sure that the employee is actually in pain or injured, is this passed on to the employee?
Well, not necessarily. Yeah, no, I would think it would not be a good thing to pass on. I can't speak for, we have over 1,000 clinicians, so I can't speak for all of them, but no, I don't think that that's something that should be passed on.
We have one from Stacy. Do patients ever get insulted when you suggest it's not physical and more in the brain, aka a neuropathway issue?
No, they could, but before you can have that conversation, you have to have established a trusting therapeutic connection with that patient. So that's another thing that we actually have been working on, to make sure we have continuity of care. If the patient sees a different person at every visit, that's just not going to happen. That kind of connection where the patient feels safe with you and trusts you won't exist. And so you have to be at that place of trust first, and then you can have any kind of conversation you want. If the patient really believes and knows that you have their best interests at heart, you care about them, you have heard them, you understand them, and this is something that you're sharing with them, that and they don't, it's fine. And usually I'll tell, I'll let somebody talk about whatever their pain is, and then I'll say, well, there's some things I've learned from the neurosciences that I think might be helpful in helping you deal with this. Would you mind if I shared that with you? And they never say no, because first you get their consent to share it, and then you share it. And once they feel that you're not just like pushing this on them, you've actually asked them, it's something you want to share, not something you want to throw at them, they're okay with it. But again, you need that trust, and you need to ask so that they feel like you're giving them a present, not punishing them or calling them a malingerer, or calling them weak, or saying it's all. Well, actually, Dr. Schubiner had another funny story. He said that he had this conversation with the patient, and she said, "Oh, Dr. Schubiner, I'm so glad that we talked about this. It's so good knowing that this is in my brain. I was afraid it was all in my mind." So to her, saying it's all in your mind was different than saying it's in your brain.
We have one more question from Francis. We send injured employees to both Concentra and Kaiser, so how do we navigate two different treatment approaches?
Yeah, well, I don't know how Kaiser's approach differs. So yeah, I'm not sure I can help you with that one. If it's like the typical Western medical training approach where as long as someone is complaining, you keep trying to figure out, a pain generator and fix that. The only way is really just to, call them and ask, hey, are you sure that, there isn't something else going on that's not structural that could be contributing to this patient's pain experience? We've heard or we've learned that emotions can feed into that. So if that's the issue, how can we change the treatment plan, or how can we include that in the treatment plan? Not to tell them what to do, but just I've learned that two wonderful words that will help you ask people to change without them thinking you're like insulting them or you're being arrogant or demeaning, is to say, I'm wondering. You can always wonder. So I'm just wondering if, based on these things that I've learned on a webinar, if maybe this is what's going on here, and just kind of plant the seed.
Thank you very much.
Actually, you know what? There are just two things. If you're looking to help employees, there are two wonderful books written for patients by someone who works in the Stanford Chronic Pain Center. And the first one, let me just grab them. The first one is called Less Pain, Fewer Pills. And they're both by Beth Darnell, Darnall. And the other one is called the Opioid-Free Pain Relief Kit, 10 Simple Steps to Ease Your Pain. They're evidence-based. They're written, for patients, so they're very accessible. They don't use medical jargon, and they offer very concrete, specific, easy instructions of things people can do to ease their pain without taking opioids, without anything outlandish that they have to do.
Thank you so much for the recommendation, Dr. Jurisic, and for the excellent presentation. This Q&A, I know for me especially, was very informative. I really appreciated the stories that you shared. As a reminder to everyone who registered for the webinar, a recording will be sent out after the webinar if you would like to view it again. Thank you for attending and have a great day.